such arrhythmias, there's a huge role of antiarrhythmic drugs. And so what happens, as we all are very much aware, I had also mentioned it earlier as well. These kind of drugs are the ones which are actually used basically for the treatment of the arrhythmias, in fact. And we have been using it arrhythmias, which do happens, in fact, not just due to the coronary artery disease, the heart attack, in fact, the heart blocks as well. In fact, there are a lot of similar causes as well for that. Yeah, I hope you all can remember. These are the basics, in fact. So, uh, what tends to happen? So, what about the mechanism of such arrhythmias? So, what tends to happen in this arrhythmias? We all are aware that uh, there are various mechanisms as well for the arrhythmogenesis. So one of the mechanism is, how about the abnormal impulse generation? So abnormal impulse generation can again further happen in different ways in the form of like automatic rhythm, otherwise triggered rhythm as well. In fact, similarly, there may be problems with the abnormal impulse conduction. So if there is a block in the impulse conduction, it could be in the form of the first degree, second degree, or the third degree block, or even through the re-entry. And we all are aware the arrhythmias may originate, for example, in the atria, the SA node, or even the AV node. And on the basis of that, you can further classify them into the supraventricular arrhythmias or even the ventricular arrhythmias as well. In fact, ventricular arrhythmias can be quite a lot lethal as well. So, to understand that, we all are very much aware of the how the normal cardiac conduction tends to happen in this. So, for example, from the SA node to the AV node, then from the AV node through the bundle of his to the different branches it goes. Okay, so there's a special mechanism for that. So there's a pharmacological rationale and goals what we try to follow. So this is how is the normal cardiac action potential which is there in fact, and which we can see very well over here. Okay, however, there can be various mechanisms which I already mentioned about the re-entry, which can be possible. Otherwise, there are accessory pathways as well. So, which are they are the ones which provide those extra pathways of conduction, due to which even tachycardias may happen. In fact, and that is how the patient will be having the complaints of the tachycardia. So, as I was telling you, so whenever you're trying to give them a medication, there is a rationale behind it. And that is what you are trying to achieve by giving those medications, in fact, right? Uh, so, as I was telling you, why are we trying to give them those medications? So, the main concept is we are trying to restore the sinus rhythm and, of course, the conduction as well, and we are trying to prevent the more serious and the lethal arrhythmias. We want the patient to be safe. We don't want any complications, in fact. So that is why we are trying to give. And of course, on the mechanism wise, it affects the conduction velocity, otherwise, the excitability of the cardiac cells by affecting the refractory period as well, and of course, by suppressing the automaticity, in fact. So, the various group of drugs, they have their own mechanism of action, in the sense like sodium channel blocker, maybe potassium channel blocker, calcium channel blocker as well. Okay, so this is what tends to happen. So if we will be looking carefully on the cellular mechanism, it's very important in the sense. So what is this showing? This action potential is classical for the group 1A drugs. So 1A drugs are the ones which is sodium channel blockers, in fact. They tend to slow the influx of sodium in phase 1, and in fact extend the refractory period in the phase 3, right? So this is the class 1B. So in 1B, if you'll be looking carefully, what happens is These are again the sodium channel blockers itself, which shorten the refractory period in the phase 3, right? So that's what we notice it over here. Similarly, 1C is the one which tends to slow the influx of sodium in phase 1. So due to the affecting in the different phases for the sodium entry, so this is how the different group of drugs they affect. Similarly, if you look carefully in the class 3, so class 3 is the one which tend to extend the phase 2 and the phase 3. Yeah, so that is why it is called as phase 3. So never forget the mechanism. So mechanism is very important, as I was already said it to you or showed it in the figures as well. 1A slows the influx of sodium in phase 1 and extend the refractory period in phase 3. Yeah. Then the 1B is the one shortens the refractory period in phase 3, and 1C slows the sodium influx in phase 1. And the class 3, as I already showed you, that extends the phase 2 and phase 3. So now further going to the classification. So what happens, the classification of the antiarrhythmic drugs is called as Vaughan, William and Singh classification actually. So there's an Indian connection as well to the classification. And what happens is they were the ones who classified into various group of drugs like class 1, 2, 3 and class 4. So what happens is in the class 1 is the one, as I already said it, it is called as sodium channel blockade because 1A is more of a moderate. In fact, so there is moderate reduction in phase 0 slope. Yeah. So that's why it increases the action potential duration or even the effective refractory period. However, the 1B is weak and the 1C is very, very strong, in fact. And class 2, we all are aware, it is reflecting to the beta blockers, in fact, which blocks the sympathetic activity, and that's why they reduce the rate and also the conduction, in fact. And class 3 is the one referring to the potassium channel blockade. Potassium channel blockade, so they tend to delay the repolarization. And that's how they increase the APT or the ERP. So a slightly group 1A action, in fact. However, for the class 4 is the one which is like the calcium channel blockade. Someone's Neha Oza. Neha Oza, can you mute your microphone? Calcium channel blockade. So as I was telling you, so they are the ones. Okay, so we have. So now let's try to have a look. Yeah. Please ask the moderator to mute the microphone. Where is our moderator? She has gone away already or what? Started the session. Hello? Please, Neha Ojha, please mute your microphone. So this is the sad part, huh? The university people start the lecture and go away. Very unfortunate. Please ask the university people to mute the microphone. Neha Ojha, please mute your microphone. Okay, in the meantime, so what about the class 1 antiarrhythmic drugs? So what happens is, uh, as I already said, most of the antiarrhythmic drugs are themselves even proarrhythmic as well. In fact, if you will try to have a look, only beta blockers are the ones which has shown, for example, to reduce, in fact, mortality, like in post myocardial infarction patients as well, in fact. So in the class 1 drugs, 1A, what are the various examples? So 1A is the one which includes quinidine, procainamide, or even disopyramide as well. So, but on an overall basis, the class 1 is the one in which are the blockers of sodium channel blockers, right? So that's why what happens is they are they show a better response of blockade, for example, in the use dependent or the state dependent, in fact. And yes, the 1A drugs, they do have slight potassium channel blockade effect as well. So as I already said it about the group 1A drugs, so they are the ones who cause, in fact, increase the APD, the action potential duration, or even the effective refractory period as well. However, for the 1B is the one which causes reduction in the action potential duration or in the ERP as well. But what are the examples? So what are the examples of uh, uh, the 1A? So 1A, I have already said it, disopyramide, prokinamide, or even quinidine. So if we look carefully over here, so they tend to decrease the slope of phase 4 spontaneous depolarizations, tending to suppress enhanced normal automaticity and induce arrhythmias, in fact. And they are the ones which possess intermediate rate of association and dissociation with sodium channels. So, about the pharmacokinetics, so for example, we are aware that prokinamide has got very good oral bioavailability, and in fact, it's frequently is also used IV as well to avoid hypotension. So what happens is this is one of the drugs as well. What happens is yeah. So it gets metabolized into the NAPA. NAPA is the one standing for N-acetyl prokinamide, in fact, and which is gets mainly cleared with the kidney, in fact. And quinidine does have very good oral bioavailability and also getting metabolized in the liver. So that is why these group class 1A drugs are used in not only supraventricular but also in ventricular arrhythmias as well. And we are aware quinidine sometimes, rarely although, has been used for the SVTs, in fact. Yeah. So, what about the toxicity? What about the side effects of these drugs? So, quinidine, we all are aware, it can be in higher levels. This itself can cause torsades or even ventricular arrhythmias as well. And what happens is they, due to increasing digoxin plasma concentration by displacing digoxin from binding sites in addition to the decreased digoxin renal clearance. In fact, we all are aware of what is called a synchronism. Synchronism is the one which is characterized by blurred vision, tinnitus, headache, psychosis, or even GI upset as well. And so this is one of the reasons. So what happens is digoxin should be administered whenever you are trying to give quinidine, when you are trying to think for, you are trying to prevent the conversion of AF or flutter into the paradoxical VT, in fact. And we all are aware quinidine is the one which shortens the AV nodal refractoriness by atropine-like effects. About the prokinamide, that is the one which causes even asystole, or in fact induction of the ventricular arrhythmias as well. And sometimes we may be able to SLE. So if the patient is taking this drug, you will be able to see like systemic lupus erythematosus as well. And now coming to the class 1B drugs, they are the ones which shorten the phase 3 repolarization and decreases the duration of the cardiac action potential. And as I had already said it to you, it tends to decrease the action potential duration and also the effective refractory period. So the various examples include is lidocaine, mexiletine, or even tokinide as well. Lidocaine, we all are aware that it's used IV route, in fact, because of its extensive first pass metabolism, and it's really a wonderful drug, especially for the ventricular arrhythmias. Similarly, if you want to use it on an oral basis, so what you can use is mexiletine, in fact. So it is literally, mexiletine is the oral analog of the lidocaine. And yes, mexiletine can be used for treatment of the ventricular arrhythmias associated with previous MI. And that's how these drugs are used for the treatment of ventricular arrhythmias even secondary to myocardial infarction, ischemia, or even digoxin toxicity as well. So now coming to the last group of the class 1 drug, which tends to reduce automaticity by increasing the threshold potential rather than decreasing the slope. So these are two different concepts. And as I had already mentioned you earlier on the action potential duration, otherwise ERP as well, there's hardly any effect in fact. So the groups or the group in fact tends to include various popular medications like the flecainide, propafenone. So let's not forget the class 1 was quinidine, procainamide. Okay. Then the 1B is mexiletine, lidocaine, and tucainide. However, the class 1C is the one containing encainide, flecainide, and propafenone as well. So, yeah, these drugs have a broad spectrum, although they have been approved for the refractory ventricular arrhythmias. And flecainide is really a very potent drug, especially whenever if you're thinking for suppressing the premature ventricular complexes or even VT as well. Although flecainide has so far did not show any mortality benefits. Yeah, the problem, one of the other problem, what has been is like the safety is not so good in fact, and especially if someone has had history of myocardial infarction, better to avoid the class 1C group of drugs. In fact, now going to the class 2. Class 2 is the one which contains beta blockers. So beta blockers, they tend to diminish the phase 4 spontaneous depolarization, suppressing automaticity and prolonging the AV conduction. So what happens is these are the ones which are negative inotropic and also chronotropic as well. Negative. So that is why they are used for conditions in which there can be sympathetic activity induced arrhythmias. In fact, something like in stress or even exercise induced arrhythmias. Otherwise, whenever you are trying to treat the atrial flutter or fibrillation as well. So some of the examples for beta adrenergic blockers include is propranolol, metoprolol, or even pendolol as well. So propranolol, we are aware that it has been a long-lasting, really, which has been present since long time. It has shown to reduce the incidence of sudden cardiac death even after myocardial infarction. Similarly, metoprolol and other select beta 1 adrenergic blockers tend to reduce the risk of bronchospasm as well. And pedolol, it has there's a partial agonistic activity which may decrease the frequency of cardiac failure, in fact. And esmolol, we all are aware, which can be given immediately, through intravenous route, not only for acute arrhythmias. I remember even for acute hypertensive crisis as well, it can be used. Similarly, the class 3 antiarrhythmic drugs. So the one was sodium channel blocker, class 2 was beta blocker. So the class 3 is potassium channel blocker. So potassium channel blocker tend to prolong the phase 3 depolarization without altering the phase 0 upstroke, in fact. And they tend to prolong the duration of the action potential and the effective refractory period. And in fact, the mechanism of action is still not clear, but it is thought that, as I said it, they are potassium channel blockers. So what are the examples? So the examples include sotalol, beryllium, amiodarone, even ibutylide as well. So don't forget these examples. These are some of those drugs which is quite a lot used often. So as I had already said it, so they are used for ventricular arrhythmia, supraventricular arrhythmias, but amiodarone can have a lot of side effects. We will discuss a little bit more in detail. So sotalol is more of a beta adrenergic blocker. right? So it tends to suppress the phase 4 spontaneous depolarization and possibly producing severe sinus bradycardia, in fact. So that is why what happens is because of its dual action with prolonged action potential duration and the negative chronotropic effect as well, it can be used for a lot of sustained ventricular tachycardia. And it may induce the torsades as well if you are giving it in a patient with structural heart disease. So better to avoid that. So similarly, Brutalium, the problem is yes, it has got very poor GI tract absorption. And amiodarone is a drug which is said like which has action of all the other group of drugs as well. So a lot of research is still going on as well, trying to understand its mechanism, what so and it has one of the longest I would say due to half life is going up to like 60 days, 2 months. Can you imagine? So for example, if you have given this medication today, so up to 60 days you may be able to see its action, or it will be there present in the blood, in fact. And it tends to affect by prolonging the action potential duration and the refractoriness, in fact. It slows the cardiac conduction, working as calcium channel blocker and as a weak beta adrenergic blocker, in fact. Similarly, amiodarone. Amiodarone, as I had already said about it, so really it is very commonly used for the common tachycardias, and it should be preferred only if uh, uh, even if the ejection fraction is slightly compromised, you can control, you can use it, and in fact it does have good rate control, and it can convert the sinus rhythm. And even before cardioversion, you can give just 300 milligrams of IV push as well for this. Similarly, for the stable VT, we all are aware you have to give initially 150 mg IV, then repeat over 10 minutes. Otherwise, you can give an infusion over 6 hours in the rate of like 1 mg per minute, in fact. And the maintenance infusion, we all are aware, you should give is 540 milligram over 18 mg. So that is in form of like 0.5 mg per minute. So a lot of times I see people who get confused, in fact. So what you try to do is initially you have to give 150 mg IV over 10 minutes, okay? 150 mg over 10 minutes. And then you give is 1 mg per minute for next 6 hours. And for the last 18 hours, you come down further. Come down further is 0.5 mg per minute. And we are aware of the various side effects like the hypertension is there, negative inotropy, even prolonged QT interval, photosensitivity can happen, otherwise even thyroid disorders, or the pulmonary alveolitis, or even neuropathy as well. And as I was telling you, the toxicity, there's a wide range of toxicity, not just GI intolerance. The patient also complains of tremors, ataxia, dizziness, hyper or hyperthyroidism as well. In fact, the patient may have corneal microdeposits, which may be accompanied by the disturbed night vision. In fact, the most common side effects includes the liver toxicity, even the facial discoloration, the neuropathy, otherwise the muscle weakness as well. And one of the worst side effects is the pulmonary fibrosis. So, for example, that's why you should also try to get pulmonary function test done whenever you suspect that. Okay. So similarly, for the calcium channel blockers, as I already said you, uh, the two most common examples for this include is verapamil and diltiazem. You should not include the nifedipine in this group of drugs. Okay, they decrease the inward calcium because by resulting in the decrease of phase 4 spontaneous depolarization, in fact. Yeah. So, and yes, the another good thing is they are, selectively for better cardiac action compared to the blood vessels, in fact. And as I was already telling you, so in fact, these drugs tend to bind only to the open, depolarized, voltage-operated calcium channels, and this is how they tend to prevent the repolarization until the drug dissociates from the channel, and that's why they are use dependent, blocking rapidly beating heart. Since we all are aware, the calcium channel blockers, calcium channels as well, they tend to have a pretty good enough time to act upon that, in fact. Yeah. So, as I already said it, these drugs are more effective or more often used for the atrial arrhythmias, in fact, supraventricular arrhythmias, and even for atrial flutter and fibrillation as well. Although, if someone's patient's ejection fraction is lower, so it should better be avoided, in fact, due to the negative inotropic activity. And both drugs may cause bradycardia and even asystole, in fact, especially when it is given with the beta blockers. So, this is another beautiful diagram in which you can compare. You can compare over here what is happening over here. So, with the mechanism of action and what, especially in relationship to the ventricular action potential. So, as we can already see, for example, for the class 1 quinidine, procainamide, they tend to moderately block the sodium channel and increase the ERP and also the action potential duration. But 1B is the one which have a weaker sodium channel blocker. So that's how they decrease the ERP and also the action potential duration. However, the 1C, like the incanide, flecainide, or even propafenone as well, they have a strong sodium channel blockade, but hardly any action on the ERP or even the action potential duration. If you look, so this is another very important MCQ in terms of like, so the sodium channel blockade is maximum for 1C, then 1A, and then B. However, if you're trying to see in terms of the ERP, increasing the ERP, so from high to low, if you will have to go, you will have to go is 1A has the maximum, then comes 1C, and then comes is 1B. So this is the beautiful diagram which is going to help us all understand about the classification and the how the classification of the antiarrhythmic drugs has been done and why it has been done. So the class 1 belongs to the sodium channel blockers, right? Affecting these two phases. Then comes the beta blockers, affecting over here, and finally the third one is potassium channel blockers, and finally comes the last one, the calcium channel blocker. But even after that as well, there are another group of drugs which I'm going to talk to you, in fact. So now I think you all are very much aware. What about its clinical applications? How can we apply the knowledge which we learned today? So we are aware various supraventricular tachycardias can be present. So, for example, if there is a sinus tachycardia patient, always try to see what is the cause for that. Yeah. So you should try to see for that. Then comes the AVNRT. So it is a very common cause of tachycardia. In that, you can think for the calcium channel blocker or even beta blocker as well. Then comes the AVRTs. So the AVRT is the one which is happening mostly due to the accessory pathway, in fact. And atrial fibrillation is the one, so especially if someone is aged, so that is when you will be seeing such arrhythmias. Similarly, atrial flutter. You may not see much, especially in those young patients, unless until it is a operated or non-virgin heart. In the sense, so for example, some alteration has not been done, or there is some congenital defects, so you may not be able to see. Similarly, atrial tachycardia. If someone is having a history of COPD, otherwise previously ablated, so then you will be able to appreciate those atrial tachycardias in that. Similarly, MAT most likely, most commonly, as I said it, if highly scarred atria is there, a lot of times, multiple times ablated for the atrial fibrillation. Otherwise, if any of those patients are having the history of COPD as well, so then they tend to have. Similarly, junctional tachycardia. It is mostly seen in younger kids, I would say, but it's not so, you know, commonly seen in the adults. This is there's another favorite drug of a lot of senior physicians, which is not so commonly used, especially nowadays, is Atenolol. So Atenolol is more of a non-selective beta blocker. It can be considered as a second line drug. So if you have already used Adenosine, Digoxin, or diltiazem as well, so you can give it. But like a beta blocker, try to avoid them for conditions like the asthma or if someone is having a poor concentration. So you all are aware about the four classes of antiarrhythmic drugs. So there is already also said as something called as the class 5. So the class 5 does include several medications as well, like adenosine, digoxin, and also magnesium sulfate. So what happens is adenosine, we all are aware, it is more of a vagotonic and also having anti-adrenergic, and but it tends to affect on the slow inward calcium current and causing the hyperpolarization, in fact. So on the ECG or even in the EP as well, we will be able to see the slowing of the AV node conduction. And the burinergic agonists is a fancy way to describe the adenosine. Currently, it is the only medication in this class, although different attempts at varying the molecule have been made in an attempt to capture patients, patents, and also increase profits at different drug companies. Its mode of action does include a direct effect on the slow inward calcium current and increasing the potassium conductance, therefore hyperpolarizing the cell. It's also a potent vagogenic and anti-adrenergic medication as well, and that's why when evaluated by using the EP study, it increases the length of time between an atrial ECG and his ECG. So it increases the time of conduction through the AV node. And we all are aware its main usage is in termination of the re-entry tachycardias. It can also be used for other atrial tachycardias as well to give AV block for diagnosis. It is metabolized in the RBCs and vascular endothelial cells. Therefore, is a short-acting medication. Its half-life is like just a few seconds, up to 10 seconds, in fact. But it's a wonderful drug. In fact, I have had just uh, especially for the usage of adenosine after AF ablation, I have like nearly 7 to 8 publications. And in fact, for the usage of adenosine after AF, also became a reviewer to the Lancet. So that was a big prestige deal for me, in fact. So it does have some drug interactions as well, like with caffeine, theophylline, and with several side effects as well. So as I had already said, since it promotes dormant reconduction, so you may be able to see AFib, even the sinus bradycardia or bronchospasm, headache, or nausea as well. So the main question remains is what does it do? Yeah. So what does this drug do actually? Why are we so much bothered about this drug? So I had already said about the mechanism, right? So it works on the A1 adenosine receptors, opening the ACH sensitive potassium channels, inhibiting the calcium in the calcium current, in fact, and that's how it suppresses the calcium dependent action potential. So that is how, and with hyperpolarization, it tends to affect more of the AV node, in fact, not on the SA node. So this drug, adenosine, tends to interrupt the re-entry and the aberrant pathways through the AV node, and thus it does help for the diagnosis and treatment of such medications. So it's a wonderful drug for the narrow complex PSVT, and the SVT, which are reliant on the AV nodal pathways. So it's a great drug, but you should not try to use it for the atrial flutter or even fibrillation or the VT as well. So regarding the contraindications, so what happens is if there is a patient with a VT or hypertension and deterioration, better to avoid giving this drug. Otherwise, if this drug can cause even bronchospasm as well, but we are aware that it's a very short acting drug, so it may be seen pretty fine. So there's a step up theory how you should be using this drug. So for example, start with 6 milligram, going to 12, going up to 15 as well, and always followed by a quick NS flush as well. And in the meantime, whenever you are giving this drug as well, keep recording the ECG rhythm as well. Yes, sometimes patient may complain of chest pain, otherwise maybe even having sometimes ventricular ectopy as well. So if you look carefully, this is the classical response with the adenosine, what you notice over here. So once we are aware of the adenosine, what about these other medications which is included? The other medications includes is digoxin. So regarding its mode of action, it inhibits the sodium potassium ATPase, and due to the positive inotropic and vagotonic action, we see various changes on the ECG as well, like it by prolonging the increasing the PR interval, it also depresses the ST segment and decreases the QT interval. And as I had already said, it is used also for the SVTs, but of course not for the accessory pathways. The T half is almost around 36 hours, I would say 36 to 48 hours as well. And if it does have a lot of drug interactions in the sense, if it is being used with comedine, it tends to increase the prothrombin time. Okay, similarly, if you are using this medication with the quinidine, amiodarone, or verapamil, it can raise the digoxin level, and the renal function or the renal tubular excretion may be affected whenever it is being used with a spironolactone. So similarly, that's the reason you should not give digoxin if there's a patient of hypocalcemia, otherwise even hypokalemia as well. Because as I had already said it, digoxin is the one which acts on sodium potassium ATPase. So if there's already low potassium, so the patient will go into severe crisis, in fact. So that's why patient will be having a lot of arrhythmias, in fact. And of course, the toxicity symptoms include the nausea, vomiting, letharginess can be there, in fact. Visual changes may be there. On the metabolic picture, if you'll try to get a ABG done, there may be hyperkalemia or even hypercalcemia. Similarly, hypokalemia or even hypomagnesemia can be seen. Okay, arrhythmias can be seen as well. VT delayed after depolarizations may be seen. And as I had already said it about the digoxin toxicity, if you're trying to treat, so what you try to do is immediately you should try to clean the GI. using ipecac or lavage or charcoal with the cathartic, right? So if the if the digoxin levels are very high, then yes, you may have to pace the patient, and otherwise, if the patient is having SVT, you can think for phenytoin or even beta blockers as well. And otherwise, for example, for the VT, you may think for lidocaine, 1 mg per kg, or even phenytoin. And always remember this, that don't cardiovert the patient with digoxin toxicity. Otherwise, the DC cardioversion may cause refractory VT or VF. So this is a very dangerous situation. What may happen due to this? So, so as I had already said it, so this is a cardiac glycoside, increases the class 1C calcium, in fact, and it does have inotropic effect. So this is the only available oral inotropic agent which tends to increase the force of contraction. And the AV node increased refractoriness, in fact, and there's decreased conduction through the AV node and the SA node. And when you look on the chronotropic action, there's overall negative action, so it tends to decrease the heart rate, in fact, and that is how it reduces the ventricular response to the supraventricular tachycardias. So, like any other drug, digoxin does also have its contraindications. So you should not give it in for patient with sick sinus syndrome or even accessory pathways. Similarly, if there is a elderly or renal failure patient, better to reduce the dose or even the toxicity, in fact. So whenever you are trying to think for the ACLS and all protocol, it's a great drug, especially which can be sometimes used, especially in relationship to the other drugs which is being used. So this is on the chart, you all can go through later on. So one of the other important drug which is always missing, I have noticed, is magnesium sulfate. So it has been included, especially in the latest ACLS protocol for the treatment of torsades de pointes. And so this is the drug which can be used for prolonged PI interval, QT interval, or even premature atrial complexes, atrial tachycardia, and even for EF as well. Similarly, if the patient is having ventricular premature beats, VT or torsades as well, this is a great drug, in fact. A lot of times, if you are coming across the hypermagnesemia, which is facilitated, which facilitates the digitalis toxic arrhythmias, in fact. So it's another wonderful drug. So that's why whenever you're already using, uh, you have used like lidocaine or beryllium as well, for example, for the VT treatment. So this is the other drug which can be of great importance and great value addition for such patients, in fact. And yes, there are a lot of clinical trials which has already been done, but have not shown too much of positive effect as well, especially about the chronic cardiovascular disease. So yes, the effect of the magnesium, as I already had said it, it has been difficult to see in cases of acute myocardial infarction, especially on tough parameters like are there any mortality benefits or not. So that's why it becomes a little bit confusing that whether it should be given or not. So as I said it, the data has been confusing. So, but we all are aware about the beta blockers and all, even the aspirin. Okay, those are definitely the drugs which should be used. But about this, it is difficult to say. And as I already said about that, it is a great therapy. It has a great therapeutic modality, especially for treatment of preeclampsia. In fact, and a lot of data has already shown that if there is a longer time between the start of myocardial perfusion, reperfusion, and the achievement of therapeutic serum magnesium concentration, it may account for null finding in the ISIS flow, in fact. So, as I was telling you, sometimes lethal arrhythmias can happen whenever you're trying to use these antiarrhythmic drugs. So that's why we should be aware about these side effects. So if we can look at already over here with quinidine or even with sotalol, the side effects can be quite a lot high. So that's why I say it like this. So whenever you are trying to use any medication, always try to be sure what are its contraindications and what are the possible side effects. So if you'll be knowing with that, you will not be doing any harm to the patient. So that's why it is very, very important. So to understand or to summarize, antiarrhythmic drugs, as I said it, yes, they are great drugs, but they do have their own side effects as well. So you have to be slightly careful whenever you are using for any kind of patient. And whenever in doubt, if the patient is unstable, nothing. You don't have to bother much, just cardio word. And yes,